Alright, gang, here we are. We finally arrived at the last chapter here on kind of tissue injury management. This chapter is on surgical interventions and postoperative management. If you go into the general outpatient orthopedic world, or if you want to work in acute care, or you work in pediatrics, you will never be able to get away from the fact that certain patients are going to have surgical interventions. And we have to know how to treat them postoperative management-wise. That's a weird way of saying that, but you guys get what I'm going with. The thing we have to really get with this is, what was the surgery for? So is this for improved function? Somebody has significant knee osteoarthritis that's causing impaired function. Well, then we want to make sure we're doing that. Is a surgical intervention kind of like we saw in patients that have severe rheumatoid arthritis? Maybe it's kind of to correct a bone deformity to improve certain function that way. Maybe people are overly loose and we actually we got surgery to kind of tighten them down. Like a labral tear would be a good example. You have a labral tear, leads to instability of the joint. We want to tighten that back down, so surgically tighten it back together. There's a lot of reasons that we can have surgery, and knowing what the reason they're having the surgery is for will be helpful in kind of figuring out what do we need to focus on in our rehab. If the goal is to improve function, then that's what we need to do. If your surgery was to stabilize a joint to prevent it from dislocating or subluxating, then subluxing. Wow, I'm having a difficult time talking. Too much coffee. Anyway, if the surgery was to create stabilization of the joint, then that's really what we want to be doing as well. And then we're going to kind of treat some of the other impairments that we think may have led to needing the surgery in the first place. So when we look at kind of the indications for a surgical intervention, you're going to get a lot of patients that come to you first, that they're seeing you and you're like, oh, you got knee osteoarthritis, and they've had several experiences with other people having this before, maybe it's their parents, grandparents, etc. But they're going to ask you, do you think I need surgery? So when you're thinking through that, here's some things that usually kind of are indications for a surgical intervention. We're looking at incapacitating pain at rest or with activity. If it's so painful that they can't do anything, well, we know that will lead to a whole other host of problems. Obesity, diabetes, all the other non-good stuff that comes from not moving around. If they had marked limitation of motion, so that'd be an example of, somebody has such a hypomobile joint that they can't function anymore. We need to improve that motion to try to let them get through their activities of daily living better. Gross instability of a joint or bony segment. When it's the instability of a joint, think of like a shoulder labrum as an example. We need to get in there and kind of tighten that labrum back down in order to create stability so the joint can move appropriately. Or it could be a bony segment. Sometimes, like in the spine, we may see one of the lumbar spine in particular, the segments kind of slide forward compared to the other ones. The problem is that kind of compresses the spinal cord, and that's when they'll start to have those signs and symptoms we always watch out for: changes in bowel and bladder. My loss of the lower extremity, the kind of the red flag questions that we ask for when there's enough of a nerve kind of pathology is causing real limitations. And we may have to go in there and actually put metal rods to help stabilize that bone structure. We could have joint deformity or abnormal alignment. So again, that's one you may have. It may be genetic, right? Some people will end up having hip dysplasia, and we have to go in there and kind of reshape the hips and put them in a certain position. Or they could have something like rheumatoid arthritis, severe rheumatoid arthritis, which led to the hands becoming almost disused. Another example of that could be that a child with cerebral palsy who's in that kind of toe up position, in that plantar flex position, can't really use their ankles very much. They may go in and cut the heel cords as an example. You can have significant structural degeneration. You can have chronic joint swelling. You could have failed a non-surgical or previous surgical management. Right? Usually you'll hear a lot of patients that says, I wanted to get surgery, but my doctor and my surgeon said they want me to try physical therapy first, and then if that doesn't work, then I will go the surgery route. So what does a bout of conservative care mean? Well, that's really kind of a rabbit hole that you may end up having to go down later. Or you can have significant loss of function leading to disability, such as what we kind of talked before. Because of anything of the above, you're so limited that you can't do anything. Well, those are usually the cancer do very well. after surgery. For the people that don't necessarily have some of these things, they surgery may not be the best first step for them. You may try a real good conservative care. If somebody has a lot of these things, then maybe my best thing is, you know what, I don't really think physical therapy is the right place for you to be. Maybe we need to try something else. When we're considering the preoperative management, so what is the goal of pre-op? Well, it's really to kind of set them up for the best success that we can possibly do. I think box 12.2 contains a lot of benefits of preoperative contact with the patient. It's a good place to kind of start. But basically what pre-op does is it gives you the ability to determine what the pre-op status is. You can see what their normal vitals are. You can see what their current range of motion, strength, balance, motor control, functional status. You can address their home and house modifications. You can already work on bed mobility and transfers, all the stuff that you may need to do later on the road, but you're teaching the patient ahead of time, which builds up the patient's confidence, usually leads to better outcomes. It also gives you the ability to educate about how this is going to go. A lot of people think as soon as I have surgery, I'm going to be fixed. They don't understand or fully grasp the idea that rehab can take a while and that sometimes the pain is actually increased in the beginning while the tissues are all healing. So you can educate the patient about what to expect from a pain management standpoint, if there's going to be certain motions that are going to get restricted because we have to protect the surgery site, and general progressions. For me, I basically, if I have a protocol, I kind of give a patient a protocol and say, this is a general guideline of what we can kind of anticipate. Understanding we may move left or right depending on how you're doing, while we ensure that we're still preventing any bad adverse actions to happen from the surgery. We want to educate on post-op exercises. Sometimes they can get patients to do post-op exercise right away depending on what the surgery is. And then also what to look for signs of infection or DVTs, and do some gait training potentially. So there's a lot of things we can do pre-hab, if you will, or that pre-operative treatment. And if we have an extended time to get that, so an example would be sometimes after patients have had an ACL tear, if their knee is so swollen, the surgeons don't want to go in and do surgery just yet because the increased swelling actually makes it harder to have a successful outcome. The increased swelling kind of degenerates whatever tissue you end up putting in there. So they'll oftentimes send them to rehab first. What they'll say is to strengthen the knee. And what they mean by that is they want you to get some of the swelling out, minimize the pain, and actually start to work on the quad strength and hamstring in particular, in order to set this patient up for success when they get out. Other considerations that we have are for the perioperative patient education. We already kind of talked about the overview plan of care. I usually give a patient what we're going to kind of expect. All those things that we already kind of talked about from the last slide. And I always make sure I note that kind of what their initial discomfort is, how we can work on wound care if there's going to be a wound, what their range of muscle tests are, gait, posture. And unfortunately, when we look at the literature, in theory, as I kind of talked about, all this stuff makes it seem like we should be set up for success, like the patient's going to have a better outcome. But there's actually mixed results right now whether pre-op leads to later improvements. And it's probably more for the patient of the comfort of the patient, the expectations that the patient has, which is probably makes it more beneficial. But it's not like their other outcomes, their range of motion, their strength, are going to be necessarily better if they didn't have rehab. So that's often why when you're like, well, we should totally get reimbursed for rehab, we often don't, because the literature we currently have just says that it's not doing what we were hoping that it would do. So my challenge is you, if you like to do research, let's figure out a way to justify our care. Now that we're post-op, the main goal for all this is really we need to design a safe, effective, and efficient rehab program. And how we do that is, one, we need to understand what the indications and the rationale for a particular surgical procedure are. What I kind of talked about before is, why is this patient getting this surgery? They have such degeneration of the joint, leading to hypomobility. We're trying to improve the range of motion of the knee so to improve their function. So we need to get that mobility back for that patient post-operatively so that we can improve their function. If they have a torn shoulder and it's leading to to instability or decreased stability, then my rehab is really going to focus on less range of motion per se and more stabilization things. If the goal of the surgery was to improve function because of joint deformity, such as in rheumatoid arthritis, as I talked about, then my goal is to protect that surgery to the best that I can and try to improve the function. So I may focus less on hitting a specific range of motion or hitting a specific strength, and more working on just the patient being able to use their hand. Sometimes surgery doesn't go fix it all the way back to 100% what it was. Maybe the goal is just to improve function by 25%. Well, let's try to get that as good as we can. You have to become familiar with the procedure of whatever surgical procedure is done. And the reason for that is because if you know what tissues are involved, if you know what had to get pushed out of the way versus what got cut through, versus what kind of things were affected by anesthesia, that will help you figure out A, what I need to protect, B, the more extensive things are, how long this is going to take, and C, will really help you figure out what kind of your special precautions are. So a good example of this, as we talked about in class earlier, was a patient has a posterior approach for a total hip replacement. So when they go through a posterior approach in order to replace the hip, so they're replacing the femoral head, and depending on it, sometimes they'll replace the acetabulum as well, or they'll put some metal in there to kind of help out. But they have to cut through the posterior capsule of the hip in order to dislocate the hip, cut off the bone, and put in the metal prosthesis part. So you know that they cut through the posterior side. So any motions that would stress out the posterior, or that I should say rather than stress, but more like stretch, any motions that would stretch that posterior capsule because you're in the acute phase now are going to be contraindicated at that point. We don't want to stretch something that we cut. Yeah, it's held together with a little bit of sutures or maybe some staples depending on what's going on. But it's still in that acute phase. We want it to be in a shortened position so that way we can allow the tissue to overlap and get those cross bridges going. And then the hardest part is we need to communicate effectively with the patient, with the surgeon, and with any other members of the rehab team. And sometimes that rehab team may be a caregiver or it may be a spouse. So you have to get really good to make sure that everybody's giving the patient the same message, because that reinforces what you want. If a surgeon is telling the patient, hey, I don't want you to stretch in a particular direction, and then the therapist is saying, yeah, we need to stretch this because we see a limitation, well, the surgeons generally carry more weight than we do, so usually the patients will listen to the surgeon. So if I'm looking at a protocol or if I'm looking at something that I don't know, my first call is usually to the surgeon that I kind of want to chat with them and walk through their rationale of some of the precautions or what some of the purpose of the exercises are, so that way we're both on the same page so I can give the same message. So basically for me, anytime a patient comes in that's post-op, it doesn't matter if I think it's straightforward or if it's more complicated. I make sure I call the surgeon. Sometimes you don't get to talk to them, you just maybe leave a message with their nurse practitioner. But I just like to touch base. I like to tell them I saw the patient, I really appreciate it, and if they could send over a surgical note, because then that way I can definitely see for sure exactly what happened, and that will give me a better idea of what tissues I need to protect. When we're doing the considerations for postoperative management, we need to think of what a postoperative exam and eval consists of. So you have a couple boxes in your book, 12.2, I think, 3 and 4, that all contain some good ideas about postoperative rehabilitation, expecting a surgical incision, because normally you don't have to do those things. You have to make sure, you got to see what the surgical incision looks like. You're going to have to get comfortable with changing bandages. And then we also need to know what other factors in the exam and evaluation are going to influence the components we put in, the progression, and the outcomes that we're expecting from this rehabilitation program. We're trying to set expectations here for this patient so they understand here's kind of a timeline of how long this is going to take. Here's how we know where things are going to go. Whenever we kind of look at the exam, the post-op exam is basically the same thing that we do in pre-op. It's just with surgical precautions. So we're still looking at vitals, we're still looking at the skin integrity, And with anybody that's post-op, our statuses can change very quickly. That can be, those are influenced by a whole bunch of different things. The amount of swelling will change based on how much movement they're doing, if they're not supposed to be doing movement. The only thing that we're just doing compared to pre-op is we're making sure we maintain those surgical precautions, and we're telling the patient what the surgical precautions are to try to reinforce, hey, these are the things we don't want you to do right now, because that will put the reason you got the surgery at risk for failing, and we don't want that to be you. And then the factors that kind of influence our progression of all this are the extent of the tissue pathology, the types and characteristics of the surgery. So what I mean by that is it a repair? So repair being you're taking the same tissue that was there and stitching it back together. A reconstruction, so there's no real such thing as like an ACL repair. You're not stitching the ACL back together. You're more reconstructing it, and you're using a different tissue. So that means like you have an ACL tear, it's a ligament. And sometimes they'll go and they'll take your patellar tendon, sometimes they'll take your Achilles tendon, sometimes they'll take a hamstring tendon. So they're reconstructing an ACL using a different structure. Is it excise? So excise means to take out. So if some things are just taken out, that will lead to slightly different kind of rehab. Or if multiple things went on. So, unfortunately, like with an ACL tear, I always go to that one because it's the easiest one, super well researched as well, is you can get what we call the unhappy triad. So a valgus collapse or twisting force on your knee in a flex position is a common mechanism injury for an ACL tear. That also can affect, if you think you're kind of gapping the medial side of the joint, so you can also get a medial collateral ligament, that MCL tear. And then the MCL attaches and inserts into the medial meniscus. So if you pull hard on the MCL, you'll pull hard on the meniscus, you get a meniscal tear. So now you got an ACL tear, a meniscal tear, and an MCL tear. Well, that's going to be a little bit longer rehab. You got 3 different structures that you're trying to help heal and regenerate compared to somebody that just had an isolated ACL tear. Your patient's status is going to affect how long this is going to take. Their past medical history, their medications they're taking. If they have diabetes, we know diabetes kind of slows the healing process down. How many functional limitations they have. What are the goals? Am I looking at somebody that just wants to get back and be able to sit on the couch and watch TV? Or am I trying to get somebody back to doing high-level activities? Whatever their social support is. Social support is super important when it comes to post-operative care. Patients that are motivated and are well supported, they tend to do better than patients that don't have those things. And also depression, right? You're getting a lot of people that have been doing a lot of things, and the reason oftentimes they're getting surgeries is because they're unable to do those things anymore, whether it's walking, running, playing sports. They want to get back to doing those things. So after surgery, you can't do a lot of that stuff for a while because we got to protect everything. So that can also lead to postoperative depression. So we got to be careful with those things, because if we know if the patient's depressed, that may decrease their motivation. They're less willing to kind of do the things that are necessary in order to improve. So you got to watch for signs and symptoms of that. The other things that will affect are what kind of tissue was involved in the surgery. We know that the less vascular the tissue is, the longer it's going to take to heal. The more vascular things are, the less time things are going to have to heal. The more things are immobilized, usually the longer it takes to kind of heal. And the reason that happens, right, is we know with the joint protection, some tissues take longer to heal. So the longer I immobilize it, the longer the rehab's going to take. It just takes longer to get unstiff. The integrity of the structures to the adjacent tissues involved. So if I'm working on a patellar tendon or an Achilles tendon, I need to know what's the gastroc look like, what's the quadricep look like, what's the hamstring look like. The better those are looking, usually the easier the rehab kind of goes. I need to know the underlying bone, like what is that attaching to? Is that bone healthy or is it an unhealthy bone? And the philosophy of the surgeon, the rehab team, and the patient. We can't forget about that. Some surgeons are a little bit more conservative. Some are a little bit more aggressive. You may be a little bit more aggressive in things you've seen more. You may find yourself being more conservative than in things you haven't seen as much. So that will also affect kind of the status as we go. if we look at the phases of the post-op rehab, it sounds very similar to things we kind of talked about already, doesn't it? I mean, we have a maximum protection phase, or kind of the acute phase. We have a moderate protection phase, or our subacute phase. And then we have a minimum to no protection, kind of our chronic phase. Well, that sounds very similar to everything that we just kind of talked about. The only difference here is the time frames are going to be a little bit longer since there's more damage from having a surgery. So each phase has goals, and the protocols kind of suggest interventions based on the needs at that time. We kind of talked about that in lab a little bit today, and we're going to go over a little bit more in our next lab as well about we can basically figure out what is the goal of this phase. We can kind of design exercises around that to hit that goal, and then we can see how it compares to what the protocol looks like. And basically, it's going to follow your tissue healing protocols. So in the max protection goal, in that acute phase, our goal is to decrease pain, prevent post-op complications, control swelling, improve functional status, and decrease disuse of the non-involved areas. In our later stages, our goal is really to get back to improving range of motion, strength, neuromuscular control, balance, stability, endurance, and functional activities. What the phases do not is they don't take into account the patient's goals, the patient's needs, and their current abilities. It also doesn't take into account if any of the surgery had to be modified and how that would change things. So an example of that is, you guys have heard these stories before. A patient says, I went in because they're going to do an arthroscopic procedure and remove some of the scar tissue from my shoulder, and then instead when they went in, they said, oh my gosh, you had a full rotator cuff tear, so we went in and repaired it instead. Well, those are completely two different rehabs if you have a scope versus if you had something that's repaired. So knowing exactly what happened, that's why I like to get the op report if I can, and I'll keep bugging the surgeon until I get it, to make sure that I know exactly what happened and that the patient knows what happened. So even there's been many times the patient comes in, I'm like, what happened to you in that surgery? Like, I don't know, doc said he had to go in and scope my shoulder, and then I'll ask him, like, they didn't repair anything? They just kind of went in and clean, quote unquote, clean stuff up? And then like, yeah, and then I'll get the post-op report, and they're like, no, they had a full rotator cuff tear, and we did a full repair. I'm like, well, I'm glad I looked. And so sometimes it's okay to be a little bit more conservative in the beginning until you know for sure what was going on. So one of the complications we can potentially have is, well, we got to play everyone's favorite game. Is this a bruise or an infection? So here's somebody that's post-op. Man, that is a lot of that joint looks like it's probably warm. It's definitely swollen. Look at all that bruising. I mean, is that infected, or is that just kind of the natural healing that's going to happen? They just had the surgery. We know it's going to be warm. We know there's going to be fluid in there. This is normal bruising that we'd actually see from somebody. What about this one? How does that look? Well, that doesn't look too good. I mean, look at all those crusties kind of on the front of the knee there. That redness, that awkward looking thing, that shiny skin. Now that looks infected. That looks like something that we would probably catch and the doctors won't, because they don't see it as frequently as we do when they're post-op. So that would be a person I'm going to say, you know what, we should probably go back to the doctor. What about this one? Man, look at all that bruising all the way down the shin. How does he have bruising all the way down into the shin if it just looks like they had a knee operation there? Well, that's an interesting thing about all the kind of fascial lines and tunnels. Swelling and fluid can kind of get anywhere. But that's normal bruising, normal swelling, so that would be just a bruise. And then what about this one? How does this one look? Again, we got some normal bruising. We got a little bit, the sutures look like they're okay. So again, this is just kind of a normal bruise. So you can't be afraid of wounds, because you got to keep looking at them every time that you're seeing them. I always ask patients, show me your scar, show me your scar, show me your scar. Because as soon as I can, when I get those staples out, I'm going hard at getting that tissue realignment by doing some scar massage. Can't let those things get down. So when we're looking at the guidelines for the preoperative and postoperative management, the keys for each phase are, well, in the max protection, we got to protect the operated tissues. We want to keep them in that short position, allow those cross bridges to heal over. We don't want to overstretch anything that was trying to be put closer together. So in order to protect the operated tissues, we need to add some immobilization sometimes. We got to make sure we protect things that need to be protected. We can add low-level stress, right? Those stress kind of help figure out, teach the collagen which lines they want to form down. We need to control edema. We've talked about this before. It's like the same thing. There's a lot of interventions we have to kind of control swelling. And then we need to decrease their pain, right? Whether that's sometimes that's me with my hands-on stuff. Other times that's me telling the doc that we're having a little bit of trouble with pain management. Can they help us out with some medications as well? That could be. It's about having that conversation. I'm not afraid, or you can't be afraid if a patient is so unwilling to do anything because it hurts so much, and I can't do any of even my passive stuff. If I'm doing ice and elevation and compression, the patient's still complaining of a lot of pain and won't participate in rehab, that may be an indication you have to talk to the doc or the surgeon and say, I'm really limited in what I can do based on these things. Is there anything you can do to kind of help me out? Then the time frame for this, so the max protection phase, depending on what was um, repaired or excised or taken out or reconstructed, this could be anywhere from a couple days to about 6 weeks or so. When we get to the moderate protection phase, well, kind of like in our subacute, our goal is to improve range of motion and joint mechanics and while the tissues heal. So we still want to protect when we need to, but we can work on improving neuromuscular control and stability and some gradual strength. And the time frame basically here lasts for about 4 to 6 weeks. And so it usually starts about 4 to 6 weeks as well. So it's nice because usually it's about 12-ish weeks when you move into the minimal protection phase, or 8 weeks. Again, it would depend on what kind of tissues were involved. And in the moderate protection phase, the inflammation's kind of subsiding at this point. Pain and tenderness are relatively minimal, and the tissues can really start to withstand that gradual increase in stress. So we want to get whatever tissues involved. Remember, bone like compression stresses, muscles like tension stresses. So those are the kind of stresses that we need to give them. And the criteria to advance to get to a protection phase are often the absence of pain at rest, and at least has limited pain-free motion. So that's, again, we're looking for when that kind of tissue stretch and pain match up into, as tissue becomes stressed, that's when you start to get a little bit of pain, rather than pain happening before any form of tissue resistance just yet. And then the minimal protection phase, this is really our return to function phase. The time frame for this, it generally starts about week 6 to week 12, and then it can last for 6 months or more. It really just depends on how much was involved and what kind of tissues are in there. We kind of talked about earlier that we know that a graft or like an ACL reconstruction, that ACL may not be quote unquote fully matured for 2 or more years, but we're going to have return to patient to function most likely before then. However, if this is their 4th or 5th or 6th ACL reconstruction, maybe we're not sending them back a year. Maybe we're holding them for a year and a half or 2 years, and we just may not see them that frequently at the end. And usually the criteria to kind of get to that minimal protection phase, usually that's about full or almost pain-free active range of motion. All the tissues are stable, right? If we had a bone fracture, we want to make sure that we have a nice hard callus at least by this point. If we had a muscle tear, we want to make sure that those cross fibers, again, that collagen, are nice and healed. And then strength can kind of vary. So there's not like you have to do this amount of strength in order to get to the protection phase. Strength's going to vary depending on what procedure that you're kind of doing. The more complicated and the more involved the procedure is, you can imagine the slower the time frames go. So if I have a repair, I have a relatively slow time frame, versus if I have a scope where all they do is go in and they just take stuff out, they don't really fix anything, so there's not really a whole lot of tissues that have to heal. So in that case, this time frame is usually relatively quickly. So when we do our considerations for postoperative management, kind of continuing on, it's kind of a combination of time-based and criterion-based progressions. So majority of protocols you'll read are going to be time-based. Week 1, do this. Week 2, do this. Week 6, do this. At week 8, they should be in the second phase. Continue on. At week 12, they should be here. So that's how we kind of used to roll, for sure. And the reason that they became that way is they try to match up with tissue healing times to the best of their ability. Usually, when things become more stable, that's when you can move into that subacute phase, and then when things are stable, that's when you can move into that um, when you can move into that minimal protection phase. So, an example: you have a fracture in the acute phase, we're in that non-weight bearing. Once we can get that kind of soft callus, the one that's not really showing up on X-ray per se, but it's been long enough that we know it's there, we may start to do some partial weight bearing. And then once we get the hard callus, so it's still not fully mature bone just yet, but once we get the hard callus, that's when we can start to do the less restricted minimal protection phase as we kind of work on that. Determining the patient's readiness to advance from one phase to another to the next should not be solely based on time. We need to keep time in consideration because we need to allow the tissue healing principles, but we should also have some attainment of predetermined criteria, such as the absence of pain, restoration of a particular amount of range of motion, or a particular level of strength. So, an example here. A lot of times in ACL rehab, that the protocols will often tell you to start running at 16 weeks. Now, why is it 16 weeks? Generally, patients are feeling pretty darn good about 16 weeks. The knee pain is relatively subsided. There's really no swelling. The strength has been coming back because you've been working on it. However, when you do a reconstruction, so you've got, let's say it's a hamstring tendon or whatever tendon you wanted to replace the ACL with, what ends up happening in the healing process is that tendon is going to have to become vascularized first. So actually, after the initial surgery, the tendon is going to start to die a little bit because there's no vascularization as much as it needs to that new ligament. So what will happen is, as it's in there, the body will start to do angiogenesis and start to get some new blood flow in there. But now you're ready to have, this takes time, right? So actually, by 16 weeks, your ACL is at the weakest it can possibly be. But patients are still feeling relatively good. So patients are like, I feel good, I want to run. And so it's hard to say, well, based on the time that we have, 16 weeks, we should be able to run. But on the protocol, I should say, however, we know that from the tissue time standpoint, this may not be the most appropriate time to begin running. How would I know when the patient can begin running? That's when you can have your criterion-based progressions. We don't have a really good, unfortunately, we don't really have a solid, hey, here's what you need to do in order to run. If you look in the strength and conditioning literature, they'll often tell you that to begin, like they consider running to be a plyometric exercise. That's kind of hopping from one leg to the next. They'll tell you before beginning a plyo program, they'd like to see you be able to squat twice your body weight. Well, I can't tell you the last time that I've seen in a protocol that you should be able to do this before returning to a run. So that's why we have those other things. I kind of told you my progression is I want to see normalized ankle range of motion. I want to see relatively good motor control and balance and stabilization from a Y balance standpoint. And then I do have a strength thing in there. I like to see 1.5 times your body weight in a squat. If you can do those things, then I feel more comfortable because you're able to use those surrounding tissues and control in order to use that as the thing that stabilizes your knee and not relying on that compromised ACL healing graft. So unfortunately, there's no consensus on what that criteria is, which is why if you were to Google return to play or criterion-based stuff, you're going to find a whole host of different things. Maybe that explains why we're not as good as we think we should be at doing our return to rehab, and we're not able to get as many people back to their prior level of function as we would like to think we could. So just food for thought there. As good as we think we are, we could be better. I would challenge you to look at some of the protocols and figure out if that matches up with what some of the principles that we have in our healing phases are. So the question becomes, right, from especially when you get into the return to sports stuff, of what would you want to see before you have somebody if somebody wants to deadlift 300 pounds, what do you want to see before you make them deadlift that? If they want to run, we kind of talk about, what about if they want to run a marathon? What kind of things would you want to see before that? What about walking without an assisted device? What if that's their goal? Well, what things would you want to have seen to say, yeah, I think you're ready for that? And what about beginning cardiovascular training? Like when can we do that? Again, there's no consensus to any of those things, but if you think through it rationally, we kind of talked about like with the assisted device, maybe starting with at least 4 out of 5 manual muscle test strength is a good place to go because you know they can at least handle moderate resistance against gravity. If they can only handle minimal, I don't know if that's the best thing to do without an assisted device. Not saying they can't do it. I'm just saying it may not set that patient up for success. And because it's so hard to do with criteria and we're so all over the place, that's why the majority of protocols you're going to see are relatively time-based. The nice part is protocols have kind of gotten a little bit better, where at the end of each phase they have, here's kind of the criteria we like to see before we move on to the next phase. And a lot of times it's more range of motion and some strength things, so at a minimum you can at least look at those. The only thing that would make me kind of slow down would be if the tissue healing properties do not match up with the way that the protocol is going. So what do I mean by that? If I know something is at its weakest, then at a particular time and they want me to do a specific exercise, that's usually a good indication to have a conversation with the person that gave you the protocol. There's a disconnect here. I'm not sure what their goal is with this. Other times it may be, like we kind of talked about earlier in the lab, that a patient's feeling really, really good, but just because they're feeling really, really good doesn't mean that I just progress them as they go. Sometimes you have to protect them from themselves. So an example with that is if I had, we kind of talked about it in class, but to elaborate on it a little bit, if I have somebody who had an Achilles rupture, acutely after the surgery, you're going to see that they're wearing a heel lift to keep them into plantar flexion. And the reason for that, we want that shortened Achilles, so then that way we can let it heal, and then we'll worry about lengthening it later. Versus, if I had somebody that had cerebral palsy, who usually has a tight Achilles, and actually, to improve the function so that they can use their foot a little bit better, I actually want to, when they cut the Achilles tendon, I'm actually going to brace them or cast them or put them in a boot that puts them into dorsiflexion. I want them to gain some length back. So I'm allowing them to have a little bit longer time to heal because I'm using the surgery to improve function versus to get back to normal function. Does that make sense? So kids that have cerebral palsy, when they become too spastic in their calves, that can lead to impaired activities of daily living, impaired function, and you're resecting the Achilles in order to get more improvement in range of motion to have better function versus your weekend warrior who tore their Achilles because they were doing too much. We need to stiffen that thing back down. So that was kind of a poor example, but I think you guys are getting where I'm going with that. Just feel free to ask me questions if you need to. So putting post-op rehab into perspective, post-op can be a very lengthy thing, and patients have limited visits. We kind of used that in topic when we were talking about how my friend out in Alaska only gets 2 visits for patients that are post-op ACL reconstruction. Versus in the military, I'm not really limited by visits. I can see a patient every day if I really wanted to, but is that the best use of my and their time? The key is we have to figure out where that balance is. We need to be effective at having long-term care. So if someone has only 30 visits, I need to be respectful of that, and I also need to try to plan it out where do you need me more? Do you need me in the beginning? Are you going to need me in the middle? Are you going to need me in the end? So having it from day one, you got to plan out the whole rehab process from there. If you don't do that, then you'll find that you are going to run out of visits often because you didn't plan very well. And if you don't get to, if you have limited visits, you run out, you're not going to see them through the whole rehab, which will happen. Sometimes patients need me more in the beginning than they do in the end. I'm still not comfortable where they are in the end, but that's when you have your other professionals you could turn to help, your personal trainers, strength and conditioning coaches, reaching out to their coaches, talking to the parents, talking to their spouses, somebody that you can have to help do the best that they can to communicate, here's the things that we still need to continue to work on. There's a lot of complications that can happen from surgery. So we have to be careful when we don't want patients to go get surgery all the time, but sometimes surgery is the only option. But a lot of surgeries, you're going to have to go under anesthesia. And anytime you do that, or anytime you cut into the body, it's just not as good as what it was before you cut into it. We know that having anesthesia and going under anesthesia, that can lead to pulmonary complications. Other things that can lead to pulmonary complications are people after post-op just don't move, so you get a lot of post-op pneumonia. You can get DVTs, you can get pulmonary embolisms for not moving. And we can watch, you may get joint subluxations or dislocations because they had something that was supposed to be tightening down and they overdid it, and they are unable to maintain that surgical thing. You can get restrictions from adhesions and scar tissue formation. You can get failure. Unfortunately, surgeries are not always 100% effective. You can have failure. You can have a knee replacement that fails. I've seen one in my career so far that the knee replacement just didn't work. You can have loosening of internal fixation device. If I move people too much, that the point of the surgery was to stabilize, and I move them too much, then I can actually loosen that fixation device. That wouldn't be good. The whole point of having them surgery was to stabilize more. And then the most common one that you end up seeing is kind of infections or delayed wound healing. And potentially you can also get nerve entrapments from different things. So we know that we can affect a lot of these things, and as PTs we can look for a lot of these things. So how do we help with pulmonary complications? Well, if we know people aren't going to move a whole lot, we can reduce the risk by doing deep breathing exercises. We can get into that diaphragmatic breath. That could be a great post-op exercise. But diaphragmatic breathing has been shown to help with pain, and it's been shown to help reduce pulmonary complications. So why not do that? And they can do that while they're doing their heel slides, or they can do that while they're doing the straight leg raises. They can do that stuff, and that's just helping you prevent the pulmonary complications. With DVT or PEs, the pulmonary embolism, you'll see those a lot if you're working with patients that have had a joint replacement. There's some good criteria to help you figure out, is this truly a DVT or PE potential. With the joint subluxation or dislocation, this is what we always talk about when we have precautions, like after a total hip replacement, is I don't want you to do these certain things, because if you do, the joint that we just put in there may pop out. So you have to really think through, what did they cut through when they did the surgery, and what motions are going to be at risk based on where that surgical scar is. And we can have the failure, displacement, or loosening of stuff if we basically progress this patient too fast. If we don't take in the time the tissue healing concepts, then that would not be a good thing. So an example would be if we had a fracture and we put a plate in there to help stabilize the fracture, and then we said, okay, day one, let's go run again. Well, we have soft, loosened bone underneath that, right? We had screws that go into bone. The bone in the middle is not really helping you out just yet, so you could lead to a failure of that part. If we increase weight bearing too fast, we can also delay the wound healing. Or an example of that is the meniscus, right? It's kind of squishy. It's meant to kind of take the forces of the ground. So a lot of times you can walk with a straight knee if you have a meniscal repair, but if you start to unlock the brace and you put too much weight on it, you go into knee flexion, you can actually tear the stitches that are in that meniscus. So you actually cause delayed wound healing. If you start lifting too heavy, if you do too strong of a muscle contraction, would be another way. So after like a total shoulder replacement, sometimes they'll actually take where the subscap inserts on the humerus, and they'll take it off, basically to create an avulsion fracture, if you will. Then they'll reattach it after they replace the shoulder. And if we end up trying to use the subscap, if we do too strong of an internal rotation, it'll actually pull the bone back off of where the humerus was, because we didn't allow the bone to heal the proper way. And then now they have a subscap tear, if you will, and so we can actually cause some other problem. So really being able to be good at what we talked about in the previous chapters about how long it takes for certain tissues to heal and become more stable, where we can load them better, is really important. When we talk about DVTs and pulmonary embolisms, I mean, this is the thing that everyone gets worried about. And it should be. It happens more frequently than we like it to do. In your book, there's a couple figures, and then there's a couple boxes that will tell you about the risk factors for DVTs, and also the Wells criteria. Wells criteria is actually super effective. My wife works in the acute care setting, so she's seeing a lot of people that are after surgery, and she swears by it. she's been very effective at finding people that actually have DVTs using that scoring procedure. Versus myself in the outpatient world, I think I've only seen a couple that have had this problem. And again, the Wells criteria was there as my way to remind myself, does this look like the person could be at risk for that? So basically what happens in these, right, a deep vein thrombosis. So a thrombosis is a bolus or a group of coagulated blood. And so basically what ends up happening is you get a coagulation of the red blood cells, and the thing that becomes problematic is if it cuts off the blood flow to that area, or if it becomes dislodged and travels somewhere like your lungs, it becomes that pulmonary embolism. So if you get a thrombosis in a superficial vein, well, superficial veins are relatively small, so there's no real issue there. That small clot can travel through the rest of the venous system and be fine. It would just get kicked out. Versus if you get a deeper vein, well, those are a lot bigger. So if you have a thrombosis in a bigger vein, you got a bigger block, and that can become problematic as it goes through some of the smaller vessels and creates an embolism. So when the clot breaks away and travels proximally, that's what's called the embolism. So if it ends up in the lungs, that becomes a pulmonary embolism. If it ends up in the brain, it becomes a cerebral embolism. Those kind of things. The signs and symptoms of DVTs, well, only about 25 to 50% of cases can be recognized by clinical manifestation. So unfortunately, you probably miss a few things that actually are DVTs. The basic signs and symptoms patients will complain of are a dull ache or severe pain, swelling, changes in the skin temperature and color, heat, and redness. And if you think about it, that makes sense. If you have a blockage somewhere, that's going to create some swelling because it's going to back up all the fluid behind it. There's a lot more blood flow in that area because it's blocked up, so you're going to have the increased skin temperature. It's going to become a little bit redder and give off some heat because of the extra blood flow. And then you may end up starting getting a dull ache because things are blocked behind that. You're not getting the same blood flow to the other side. Risk factors for that, well, risk factors are post-op, prolonged bed rest, prolonged standing, sedentary lifestyle, trauma, limb paralysis, an active malignancy, being older, having obesity, cardio problems. For ladies, pregnancy is one, and then also oral contraceptives is another thing that has led to more DVTs. So things to kind of watch out for. So if I have a patient that's kind of hitting a lot of these things, then I'm more cautious. I'm more prepared to be looking for that kind of DVT. So anybody that's going to be working with patients that are post-op, which most of us are, you really got to know what your Wells criteria is, and that's in box 12.7. So if I was a betting man, I'm going to guess that a couple questions are going to be on that box. When we look at the signs and symptoms for a pulmonary embolism, remember that's a thrombosis that broken away and has gotten to the lungs. The risk factors are the same as a DVT, but the signs and symptoms, those are going to depend on the size and to the extent of the lung involvement and existence with the other coexisting cardiopulmonary conditions that they may have had. So the hallmark sign that we have is really shortness of breath. So basically, right, you got that embolus, it's blocking the blood flow to the lung, and then so your lung is not functioning as well. So that would lead you to be have a little bit more shortness of breath. It will lead to rapid and shallow breathing. So shortness of breath, right, that's that dyspnea that you'll hear. The rapid and shallow breathing, that's the tachypnea. And then a chest pain located at the lateral aspect of the chest that intensifies with deep breathing and coughing. And again, because you have this blockage, the more you try to use the breathing or the harder that you contract with the coughing, you'll end up finding that there's that local chest pain. Versus somebody that has having a heart attack, right? You're not going to really see the pain. Oh, well, I didn't realize music was going. My bad, guys. No, sorry about that. If you're hearing that music, my phone was just going off in my pocket, having a good time. So, anywho, where was I? Other signs and symptoms of the PE. Well, that could be kind of swelling um, in the lower extremity, anxiety, fear, excessive sweating, which is diaphoresis, cough, blood in the sputum. Um, if you see any of those things, that's when you're basically going to seek medical attention. That's do not pass go, do not collect $200. You're going to the emergency room now. It's a severe thing. We got to make sure that that's not happening. Pulmonary embolism can lead to death, so let's not take a risk and do those things. So here's kind of a look at the Wells criteria. So you notice that it talks about swelling, it talks about pitting edema, it talks about having a previous history of documentation, it talks about having active cancer, calf swelling, localized tenderness along the deep vein, paralysis, recently bedridden, or major surgery. So unfortunately, right, when we look at this, we're like, oh my gosh, patients that are post-op, they can have all this really quick. I mean, the fact that they just had a major surgery, they're already at +1. Well, that doesn't bode well for us sometimes when we're looking at the Wells criteria. However, we know that with this, we know exactly what just happened to them, right? So just because something is it swollen along the deep venous system, or is it just more that local edema or local effusion, depending on what happens? So that's why you have that alternative diagnosis as least likely as DVT, you get that -2. So you have to really take a good history. You got to see what's going on, and if your score is, I think it's, I have to relook. Is it 1 or 2? I can't call off the top of my head, but if you have something like that, then it becomes more likely that you have this problem. So that would be when you need to send the person. Worst case scenario, they get a Doppler, which is the way they can look at the blood flow. It comes back negative, and then you can say, okay, good. If you don't have it, let's continue on. So I would know that box. If I were you, probably a good thing to look at for sure. So reducing the risk of DVTs, you often see that patients go on prophylactics or the use of anticoagulants after surgery, elevating our legs, no prolonged positioning. Hey, I know you just had that surgery, but let's get up and move. We talk about that all the time, especially if you're going to be in acute care. It's like as soon as we are done, we're moving, doing the best that we can. Initiate early ambulation. Again, we just don't want people to sit in for a long time because if we can get a movement that gets the blood pumping, less likely you're going to clot when you have more active blood moving. That's why you got the active pumping exercises too, ankle pumps, those kind of things. Less of you may have seen some of the machines that kind of squeeze your foot and then it relaxes and it squeezes your calf and then it relaxes. Well, those are more the passive pumping exercises. They're not as good, and the literature is not great on saying that they prevent DVTs, but the active pumping, doing your own active ankle pumps, that has been shown to be much more effective because you're getting that active contraction, you're getting that active muscle pushing the blood out and back through the system. So you're not getting that stasis. The stasis is really what kind of sets you up for failure when it comes to getting a DVT. Compression stockings are another good way. And then that's when the sequential pneumatic compression, that's kind of that little squeezing thing that we have. Worst case scenario, it's not going to hurt anybody. It's just not as good as some of those other things that we have. We definitely don't want any prolonged sitting, particularly if you're in a long-legged cast. It's just when you got less, if you're in a long-legged cast, you can't use your quad, you can't use your calf, you can't use anything down to your leg. So there's a lot more stasis that can lead to developing of the DVT. Nice thing about ankle pumps, which I think is cool, right? So it's that active ankle exercises. One thing that I was like, those seems so silly. I don't even know why I'm doing these things for some of these patients other than just doing it for ankle range of motion. But the literature will actually tell you that if you do ankle pumps for 1 minute, you're going to have increased venous blood flow for up to 30 minutes after a total hip replacement. And that's really cool. So basically what that tells me is if for every 1 minute of ankle pumps I do, I got 30 minutes of blood flow. So how often do I want patients to be doing ankle pumps? I want them to do them at least twice an hour. Does that make sense? I want to keep that blood flow moving, less and less likely to develop that DVT. Sometimes the best thing we can do is prevent the bad things from happening. So continue on with this when we have the management of DVT. Box 12.8 is really good at kind of outlining the guidelines for those things, so I'd take a look at that. And we have a clinical practice guideline for DVT, so take a look at that as well. I got the role of the physical therapist in the management of individuals at risk for DVTs. I think that's really nice way to kind of look at everything together. And the reason for that is our goal is not to let them, if they have a DVT, okay, we do not want that to become a PE. So we're going to give them the anticoagulation. We'll do some bed rest. We'll elevate the extremity. We'll do some graded compression stocking. The bed rest time for that basically varies from a few days to a few weeks. Our goal during the bed rest is we're trying to get the blood levels to be appropriate when it comes to the amount of clotting factors that are there. Once we get those under control, we can begin exercises. So during the bed rest, exercise is usually contraindicated at that point because the movement usually causes pain. Less that the tiny movements we may do will dislodge the clot and become a PE. It's more that it's just super painful when we're putting somebody on bed rest. So once we get the therapeutic levels of the anticoagulation, we're going to begin walking with compression stockings. Contraindication here, moist heat. We do not want moist heat for that person. Why? Because moist heat is going to vasodilate, so if you have a clot, it's actually going to be able to break away more easily. This is why we're wearing the compression stockings. It's helping kind of keeping everything together, and we're not letting things vasodilate as much. So once we get those things under wraps, that's when we're going to try to get our exercises going. Another contraindication, but while things are not in the therapeutic state yet, we don't really want to be doing a whole bunch of active or passive motions, or we don't want to use the sequential pneumatic compression devices because, again, we're not trying to push that clot out. We want to get the levels looking okay before we get up and move a little bit more. So no box 12.8, that'd be super helpful as we move forward. And one last thing here I thought was very interesting is in an Aldrich systematic review, they showed that, I mean, it's very fearful. This is a very serious thing, having a PE for sure. People often get afraid and don't want to do anything with patients. But in the Aldrich systematic review, they show that ambulation within 24 hours after anticoagulation therapy, well, that didn't increase the pulmonary embolism if there was no existing pulmonary embolism and they had an adequate cardiopulmonary reserve. So basically that means if they have a known PE, you got to proceed more cautiously. And if they found that if we can get them up, you're not increasing them for more risk if they meet those criteria, and you're actually going to have a more rapid resolution of pain and swelling. So generally, after these patients get out of the hospital, after they're done with their bed rest, so the post-hospitalization precautions, basically what ends up happening is they're on anticoagulation for medications for 6 or more months. Sometimes they could be on it for forever. Basically, the things are going to be kind of limited. So if you guys follow any sports, Chris Bosh from the Miami Heat, he ended up having some DVTs, and basically what ends up happening is you kind of don't want to take any extra risk, right? So there's going to be no contact sports, no skiing, no running, but you can walk on the treadmill or you can jog on a treadmill or use the elliptical. And you have a mandatory helmet use. Now, why would you have a mandatory helmet use? Well, basically, you're on so many anticoagulation meds that if you were to hit your head, you could potentially bleed out. You're not going to clot because you're on anticoagulation meds. So usually you'll see that those people will wear helmets when they're doing activities like walking on the treadmill or things that put them at risk of potential falls where they could hit their head. So that's something to consider as well, and not necessarily only on patients that have this, but these patients in particular because they're on so many anticoagulation medications, but also someone to consider if you have a different patient that's on some other blood thinners as well. So moving on to the surgical approaches, basically there's a lot of different types of surgeries, and in the book it has a nice table that kind of gives you the general methods and examples of different MSK surgeries. Chapter 17 to 22, those also contain a lot more extensive descriptions of each of the surgeries themselves, and then like kind of progressions and post-op management more specifically. But basically, when you look at a surgical approach, the idea is how much tissue was cut through, pushed aside to get to what we needed to do, and then once we got there, what did we do to the tissue? Did we repair it? Did we just take something out? Did we change something? Did we put a ligament in place of a tendon or a tendon in place of a ligament? Kind of things of that nature. When we look at open procedures, or sorry, so broad surgical categories, and I said, do we repair something? Do we replace something? Did we replace something with something else, like a reconstruction, took a tendon, made it become a ligament? Did we stabilize something? Did we tighten everything down? Did we transfer something? Did we take one thing and put it somewhere else? Did we release it? Did we cut it so that it opens up? Did we excise it? Did we take something out? Did we fixate something? Did we create a fusion? So based on those kind of categories, it kind of gives you an idea of the more involved the surgery is, the more things that I cut through and changed and repaired, then the longer the duration is. The more things that I just kind of took out where I didn't repair anything, I just kind of shaved some things down to open up some more joint space, the less precautions I'll have. So when you look at open procedures, that's like what you've seen in the medical shows where they go through the giant open heart surgery. They break the rib cage, they peel it open, and the purpose of that is because they're trying to visualize the field to the best of their ability. Because you have to cut through a lot of stuff, you cut through skin, you cut through muscle, you cut through bone, whatever it is you have to get to visualization, you have extensive tissue damage, and it requires a very long rehab because you have to let every single one of those tissues that you had to cut through to get to what you need to do heal. Arthrotomy is arthrotomy. Arthro means joint, right? Remember those? Arthrotomy is used to describe an open procedure in which the joint capsule is incised to expose joint surfaces. So, an example of that would be like a knee replacement, a fusion, internal fixation, some form of soft tissue repairs as well. When you're looking at an arthroscopic procedure, that's what people call a scope or a cleanup. So basically, arthro meaning joint, and then scopic meaning with a scope, hence the name. Basically, those are looking for a couple different things. You can use them as a diagnostic thing. So sometimes our images aren't the best. Sometimes you may not see something on an MRI, you may not see something on a CT scan or something of that nature. So they'll go in and what they call an exploratory surgery. So basically, they make two small incisions, they put in the camera, and they look around. You can use it as a surgical thing if I can with an arthroscopic procedure. If I can, sometimes when I go and I look into a joint, I may find that or when they say like a cleanup, that you may have some frayed labrum, you may have some frayed muscle, and so what they'll do is they'll go in, they'll take a little shaver and they'll kind of shave some things down. So they're kind of excising things at that point. Because they're not really repairing anything, um, there's really no prolonged rehab because all they did was just take some things out, shave some bone down. So the rehabs are relatively short. Nothing has to quote unquote repair. Versus they can also use an arthroscopic procedure where they go in to make those small incisions, but then they can actually repair things when they're in there. So this is often done for like rotator cuff repairs when they're going to stitch. So even though they use the arthroscopic where they put this camera in there, what they're really doing is they're repairing a tissue. So then it becomes more you're looking at the repair. That becomes how long it's going to take you to rehab. They do the same thing when they do a ACL reconstructions. It's also, most of the time an arthroscopic procedure where they just have two small incisions, but then they're also repairing the tissue. So if they have an arthroscopic procedure, you really need to know what did they do. Did they just kind of shave some things down, or did they actually repair some tissues? Then there's different type of tissue grafts. So the type of tissue grafts will help you figure out how long things are going to take. Auto meaning self. So an autograft is their patient's own tissue. Uh, but that means you have to have two surgeries. So if I'm going to have an ACL reconstruction and I say that I'm going to take my hamstring tendon to do that, then they have to go surgery number one, go get the hamstring tendon, and surgery number two, use that to replace the ACL reconstruction. So the reason that we like autografts is you have less of the potential infections or rejections. It's your own tissue. Your body won't degrade it because it's the same thing. An allograft, so what allo means is the sorts that's not the patient but of the same species. So that would be something like a cadaver graft. I use somebody else's ACL. I use somebody else's hamstring graft. Now that's typically used when previous autografts have failed or it's not available. So if I don't have the thing that I need, then I'll go to allograft. The risk is potentially you can get disease transmission because you got somebody else's graft in there. You may have decreased graft strength because in order to get the graft ready for you from somebody else, they have to sterilize it, and the sterilization can lead to a weakened graft. And you can also have rejection. If the tissue types don't match up, you may get regression. You can't use allografts for articular cartilage because in order to do that, you have to freeze them to store them. And so when you freeze them, it actually destroys the chondrocytes. So in order to try to do cartilage grafts, you have to have an autograft. Synthetic grafts, man-made ones that we can try to do, they're not nearly as good as auto or allo, but it's something that you can look into. And then a xenograft. Xeno is the sources, not the patient, and it may be not of the same species. So you'll see this a lot in heart transplants. You may actually get a bovine valve, which would be a part of a cow heart, or you may get a pig valve as well. They don't. We're starting to use them more in ligaments. You may get some pig ligaments for some knee things. They're just not as common. It's more common in a cardiovascular situation. When we're looking at the repair, reattachment, reconstruction, and stabilization or transfer of soft tissues, basically what we're talking about here is muscle repair. So if we're repairing a muscle, we got to think of the post-op considerations. We got to think of that tissue healing time. If we're thinking tendons, we know that there's less blood flow here. This is probably going to be a longer rehab, and most of the tendon repairs, usually where the tendon will tear, is going to be at the transition type between muscle and tendon or tendon and bone. Those are the more common ones. It's the transition that makes it slightly weaker than if it was just all one source. There's a lot more information on tendon repairs in the shoulder in chapter 17, fingers 19, ankle 22. So the later chapters in your book have a lot of good examples of both ligaments and of and of muscles as well. And the reasons we would look at these things, I gave you a nice video link there to kind of look at an ACL reconstruction. It's pretty cool. I would check it out. And the reason that we may have these things are severe injury, we need increased stabilization, we need to decrease unstable or increased motor control joints would be reasons that we would do a repair, or reattachment, or reconstruction, or stabilization. So it's exactly what we need. If we're saying that someone needs stabilization, we'll do a stabilization procedure where we kind of cinch everything down and tighten things up. It often happens in labrums. Repair, that may be a muscle that's torn or a leg or tendon is torn. We need to repair that. We basically stitch it together. Reattachment, that would be like you have a bicep tear that actually pulled away from the bony surface. You may have to reattach it up there. Or sometimes they'll do a reattachment surgery after they'll relocate a tendon or a muscle to change where the line of pull is. We'll see that in the shoulder when we particularly get to MSK next year, and we're looking at patients that have a bicep transfer. With the muscles, we know we need to do an immediate repair is not nearly as common. And what I mean by that, so in a muscle, after you injure muscle, usually you have a lot of inflammation, which changes the texture of the tissue. So because the tissue textures change, we usually find there's a decreased ability for the sutures to hold. So if you tear a muscle, it's often delayed for about 48 to 72 hours after the acute symptoms have kind of decreased in order to allow that tissue to have the best chance of being reattached. With post-op, it's very similar to the non-surgical treatment things. We generally do an immobilization in a shortened position, perform gradual muscle sets. After immobilizations, we're going to work on active range of motion within a controlled, protected range of motion so that we don't stretch out the scar and the sutures that are holding things. We'll work on increasing range of motion, decreasing contracture as we get along. Weight bearing may be delayed until we have a functional level of strength for something down in the lower leg. In low loads and high repetition without pain to protect healing, right? We know that the first thing to go is those endurance ones. That's why I got the low load high. And we're going to kind of avoid vigorous stretching and return to activity until there's some healing has been complete. And that usually shows up about when I mean healing complete, what they mean by that is you have a stable scar. We can add in some stress. So that may be more appropriately like 6-ish to 8-ish weeks, depending on what muscle is involved. With tendon problems, when we have tendon repairs, tendon ruptures are usually in a younger population. It's because of trauma. In an older population, usually that's when we have kind of the progressive deterioration coupled with a sudden or unusual forceful motion. So this would be an example if you got your person in the mid-40s, generally it's guys in this one, the weekend warriors, and they haven't been exercising the way that they were, and they're like, you know what, I'll get back into some P90X or some Insanity, because I used to do that when I was in my 20s. They have this sudden increase in unusual forces that they haven't done, and then they rupture their Achilles. So the rupture usually happens at that musculotendinous or the tendon-osteo junction, that transfer zones that I kind of talked about. And then with surgery, this is actually often repaired immediately, and the reason for that is if we don't repair it immediately, if we allow the tendon to start to scar down, it's going to scar down to whatever's right below it. So the tendon will actually retract and it will get shorter, and that will actually make it very difficult to reattach, right? If we shorten up our tendon, it's going to be harder to put the two pieces back together. So in a post-op position, we're going to basically put it in a shortened position for longer than muscle because of the decreased blood supply, right? Tendons don't heal as fast as muscles because they have decreased blood supply. So if I had an Achilles rupture, and I wanted to repair that, then I would put them in a position of plantar flexion and keep that with the heel lift would be an example. Now that would be if I had an Achilles rupture. You may have where you get they're doing more of a excision where they're slicing the Achilles to gain length, and somebody that has cerebral palsy like we talked about, and in that case they would actually put it in a lengthened position, a little bit more in dorsiflexion. So it really depends on why you're getting the surgery. Are we doing it for function for kids with cerebral palsy, or are we doing it because we had the tissue that was torn and we needed to repair it? And because, going back to tendons, because you're in a shortened position for a longer period of time, range of motion may be slightly more difficult to regain. And because we're not really going to be able to do any vigorous stretching at least for 8 weeks, because again, it's taking a longer time for things to happen. We have reimmobilization involved to a limited degree of tensile forces on repair as soon as we can, and the reason for that is we're trying to minimize adhesions that would hinder the tendinoglides. We can do muscle setting immediately to kind of try to get that muscle from atrophying too much, and we can do active contraction of the antagonist of the repair within a protected range within a few days after surgery. Excuse me. So what I mean by that is, if we had an Achilles rupture repair, then we can do active dorsiflexion before we would be allowed to do active plantar flexion, and before we're allowed to do passive dorsiflexion before we can do eccentric load of that calf. So we have to know what the tissue loading principles are. I can do active contraction of the antagonist. So if it's the gastroc, the antagonist would be the tibialis anterior within a protected range. That would be okay. We want to avoid passive stretching into where it would stretch the Achilles out. So I wouldn't do passive stretching because that would tear passive stretching into dorsiflexion, because that could potentially re-tear what was just sutured together, if that makes sense. So we want to do more active stretching by inhibition, by having if I have the tibialis anterior working, the gastroc cannot be working. They do opposite things. So I'd rather use an active quote-unquote stretch versus a passive stretch. We may be in a controlled anti-gravity motions for several weeks. Weight bearing is often restricted depending on where the injury is, and we're going to have no heavy lifting for 6 to 8 weeks or more. We got to really let that tissue integrity get repaired. When we look at the ligaments, sometimes we can have repair, which is we just stitch the ligaments back together. We can have a reconstruction, which is where we use a different tissue graft. An example again was the ACL could be replaced with a hamstring, an Achilles, palmaris longus. There's a bunch of different grafts that people can use for that. And with the procedure, the joint is often held in a position that places a safe level of tension on the suture or reconstruction. And the reason for that is we need a little bit of that tensile force to help stimulate with the collagen and the remodeling that we need to have. Again, you're taking a tissue that wasn't what it was, so I'm taking a hamstring graft that is a tendon, and that is not the ACL. So it would take a little bit longer to remodel, as that tendon will start to lose its tendon properties and become more like the ACL ligament. It's never going to be the exact same as the ACL ligament, but it kind of, the body says, you need me to change into this, and it could start to change into that. So this rehabs are often a little bit longer when you're taking a graft from somewhere else. Immobilization for this, the length varies depending on the site, the severity, and the type of repair. With post-op, early protective range of motion, weight bearing, and strengthening to load the healing tissue, but safely. So we want to put a little bit of stress in there, but we want to keep it safe. We don't want to add any too much stress that could disrupt our healing process. And progression depends on a bunch of factors such as the type of repair, the size of the repair. An example of this would be a patient that has an ACL reconstruction. If you have somebody that has a bone, patella, and bone graft, they can generally be progressed faster than somebody that has a hamstring graft. And the reason for that is with the patella graft, you take two parts of the bones on the end, and those actually, bone will heal faster than tendon and ligament does. So the new ligament, if you will, that bone, patella bone, will actually become stable quicker because the bones will become part of the other bone faster than somebody that has a hamstring graft. We got to let the original bone kind of close down the hole. It's actually really cool when you look at some literature on that. The unstable joints will often have external support for longer. So if you're having your ligament because you have an unstable position, you may have to keep them with external supports or braces or something of that a little bit longer than if you didn't have that. The duration of this rehab generally takes approximately 6 to 18 months. It really depends on how much is involved and what the patient is trying to get back to. So there's a lot of factors that go into why one surgery would be picked over another. Kind of continuing on that, we may get some stabilization. That is when they literally come in and they try to tighten everything down. It happens with labrums. You can get a capsular shift where they try to basically fold one thing over. Their book does a really good job explaining this. They do it with the labrum sometimes. You can do electrothermal assisted capsulography as well, which is basically they try to dehydrate the tissue in order to shrink it down. They're really cool things. And then basically the dehydration, happens in the collagen and it breaks up the hydrogen bonds. Remember all of that? So it breaks up the hydrogen bonds and actually will tighten some things up. So the goal for these surgeries, or for the capsular stabilization stuff, is basically to create more stabilization, to restore the balance of stability and motion while protecting the capsules. So that is our goal. Is we have to restore the stability. We have to get the motion to the best we can without compromising the other tissues. So there's usually a period of immobilization to let things stiffen down. They emphasize active range of motion as not prolonged stretches, but to do more active, assistive, and kind of inhibition things. And the reason for that is we already know we tighten them down because they were too loose. So we wouldn't want to do passive stretching because that would loosen them back up. We probably wouldn't want to do a whole bunch of grade 3 and grade 4 mobilizations on a labrum that had been stabilized because we don't want it to be loose. That's the whole point of the surgery. So the main goal with these folks is we're really working on the stabilizer muscles. We want to enhance the stability by working them. So that'd be an example of the shoulder labrum. We really want to work the rotator cuff as a really good shoulder stabilizer. With tendon transfers, we may do that for increasing stabilization of the joint, and it can change the line and pull to help decrease the deformity, increase functional control. So if you end up moving a tendon from one spot to the other, you're going to change the line of pull, and that changes the action. So an example of this in kids with cerebral palsy, sometimes they have different difficulty with their opening and closing their hand. So in order to increase the grasp, they'll actually take the flexor carpi ulnaris, which inserts into the dorsum, or they'll take it and insert into the dorsal side of the hand. So now you actually take it from being a flexor to an extensor. So it allows kids to get out of that kind of flexed posture and get into a little bit of extension. Basically, if the post-op protocols require, you're going to put things in a shortened position. You can do early muscle setting and protect the motion to help preserve the tendon that can glide back and forth. And if the purpose was to change the function, then I want to use biofeedback e-stim to help facilitate that. So again, that kid with cerebral palsy, I will basically put some stim on the back as they work into extension. I can use electrical stimulation to help create emphasis into making that muscle do that now. You can also do releasing, lengthening, or decompression of tissues. So basically what ends up happening is myotomy. You're cutting the muscle. Teno, you're cutting a tendon. Fascio, you're cutting the fascia. And so that could be a lot of things. I may do a fascial release if I'm having what we talked about before with that compartment syndrome. I may cut the tendon for lengthening purposes, again with that kid with cerebral palsy when I'm trying to lengthen the Achilles. I can do a decompression. That's the same thing as kind of doing that fasciotomy. Um, so the reasons you do that a lot of times are increased range of motion, decreased deformity, decreased pain. And with post-op, actually for these people, right, our goal is releasing, lengthening, decompressing. We don't want to put immobilization in a short position. We actually want to put these people in a position of lengthening because we were trying to open the area. So that's when you may see you can get things like active range of motion within one or two position and the soft tissue heals. You have to just consider what tissues were injured and then add range of motion as appropriate. But you're really going to strengthen the antagonist of the lengthened muscle early in order to help maintain active control of the movement within the new range. So again, if I am lengthening the Achilles, the Achilles works with plantar flexion. So part of my rehab, I am going to put them in a immobilization and dorsiflexion. I'm actually going to strengthen the heck out of that tibialis anterior because that will actually keep the length of the tissue that I just lengthened on purpose. I don't want it to scar back down and get in that short position. So when we're kind of looking through these things, we have joint procedures. We can have an arthroscopic. Remember, that means that they're doing just the two incisions. The debridement, that's when they're kind of going in and doing that shave down kind of thing. So this is what this kind of looks like here. You can see they got their tools coming in. You'll notice in the pictures kind of in the middle here, you can see these kind of frayed things. Those are the things they'll go in and actually take a little shaver and they'll shave those down. There's some more right here that these are supposed to be nice and smooth and we're not seeing that. What you're looking at here, this is what the meniscus would look like. So you can see as we come around here in this picture, we have on the bottom left there, you can see there's like those little hairs coming off. Those are the things that they would actually go in and kind of shave down to make it look a little bit nicer. They're debriding the joint, so you hear that term used a lot. They're not repairing anything here. Ooh, this picture right here, this is actually the ACL that they have. So it looks cool. You can see how those fibers all run in one direction. The picture there in the middle to the left. So they're not actually repairing anything here. They're just opening up, they're debriding it. They're shaving down the things that are kind of frayed off. So the nice part about these is these patients generally progress relatively quickly because there's really no protection needed. You didn't repair anything. You didn't stitch anything. All you did was kind of excise some things. You can have a synovectomy, which means you take out part of the synovium. There's articular cartilage procedures. The hard part about articular cartilage procedures is that there's a limited capacity to heal. Remember, our cartilage does not have a lot of blood flow to it. So there's a lot of procedures that would look at articular cartilage. The reason you would pick one procedure over the other is based on the size of the lesion and patient factors such as age. So abrasion and subcondylar drilling, what those will do is those will help stimulate bone marrow response, which leads to growth of fibrocartilage. Now, fibrocartilage is not the same as normal cartilage, which is hyaline cartilage. So even though we do this, the healing process is not the same kind of cartilage. So we don't see a ton of great outcomes when it comes to looking at comparing these patients that are post-op from this. We can also look at things as microfracture. That's becoming much more popular nowadays. Microfractures are really used when you have a defect in the cartilage that's more than about 1.5 centimeters. It may be beneficial for younger patients with smaller defects, but not to the point where they have osteoarthritis. Remember, when you get severe osteoarthritis, you've gone through the cartilage and into bone, so just repairing the cartilage on top may not actually change what you really want to. There's chondrocyte transplantation, so that's used for defects that are a little bit larger. So the microfracture is less than 1.5. I think I said greater, so my apologies. It's less than 1.5. Chondrocyte transplantations are used for defects that are larger. So microfracture, you're basically poking small holes in the bone, trying to stimulate a healing process. In smaller defects, when you have a larger one, you actually have to take a chondrocyte, or basically the things that make the cartilage, and you're going to take them from one spot and you're going to put them into another, and you basically put a bunch of pieces in and hope that it fills. So there's usually a two-stage procedure for that. Usually you're doing healthy cartilage gets harvested and then cultured, so it's cultured so it grows a little bit more, and then you get debridement and you cover that site with the culture at the second stage. The other thing you can do is an osteochondral autograft. So that's a osteo bone, chondral cartilage. So osteochondral grafts are a combo of bone and cartilage. You end up having to make, in order to get that, right, basically they're drilling, they're taking some bone and they're taking some cartilage. So they are creating defects somewhere else in order to, at the donor site, in order to fill in the defect at the site that's painful. So they try to take the donor sites as places that don't have a lot of weight bearing, and then that way they can fill those spots that don't really get a lot of stress anyway, and take it and put it somewhere else. If you do this by yourself, if you take an allograft of this, most of them have to be done within a few days because you can't freeze those cells. If you freeze them, you kill the chondrocytes, so it kind of defeats the purpose of the procedure. The hard part about a lot of these things are, man, these post-ops, you don't have a lot of good healing because cartilage just does not have a lot of good healing. So the post-op is slow and arduous. You have to do minimal passive ranges of motion. You can't really have people weight bearing just yet because you don't want to break off the defect. So basically the people are protected weight bearing to promote the healthy chondrocytes and osteocytes, and they may be full weight bearing by 8 to 9 weeks. So you're talking 2, maybe even working your way towards 3 months before this patient can even really weight bear as appropriate. So the recovery time for this is very long. It's usually about 6 months to about 12 months. So this will be an example of that osteochondral autograft. You'll notice that up here there's a bunch of holes. This was the donor site. They took the holes here to try to fill in this defect down here. So it kind of looks like a honeycomb looking thing. And then their hope is that those will kind of fill and grow, and then that will fill in the gap. The literature, the evidence is not super good, if you will. Sorry, super good is not a real good term, but we're just not great at this just yet. There are mixed reviews on how this goes. And a lot of it ends up being, what kind of rehab do you get? That's the more important thing. This would be another example when they went in. They harvested some bone sites, as you see here, where they have those holes. They've taken them out, and then they go in, and this is what it looks like in a live patient, where it looks like they kind of shoved cotton balls in their leg there in that F picture. And then they hope that it heals and that it's no longer painful. So it's kind of one of the things where if nothing else works, let's try this. So then we can get to an arthroplasty. So what arthroplasty means arthro joint plasty means they're doing something to it. They could potentially replace it. Excision, right? They're just taking some stuff out. So excision arthroplasty may be used if a patient has if a patient has like a leg length discrepancy or a bony abnormality, the space that's left, so they take a little bit of piece out and they leave it, and basically it gets filled with fibrotic scar tissue. So the reason for that is that it's not just used much because the healing tissue isn't very awesome, and it may lead to more joint discrepancy or leg length problems or muscle balances and weaknesses. Sometimes you can use an implant. They use like a silicone implant. That silicone implant basically becomes encapsulated by fibrous tissue. You use it to try to help remodel or shape the joints. It's often done to replace the meniscus or a spinal disc to try to help absorb some of the forces that are going through and make it so that one side's not down compared to the other. You can do an interposition, which basically that is a debridement with the new articulating joint surfaces. They often use like a tendon or fascia or silicone or metal, something to make that the articulating surface. It's more used when patients are younger and who aren't really appropriate for joint replacement yet. And the reason for that is, joint replacements don't last forever, so I don't want to have them get multiple joint replacements throughout their life. And then you have your joint replacement with arthroplasty. So joint replacement is exactly what it sounds like. They're changing the surfaces here. So this is really the bread and butter and the cash cow of the outpatient world. You can have different types of joint replacements. You get a total, which is both surfaces were replaced, or you can have a hemi, which meaning only one surface is replaced. One surface is going to be metal, and one surface is going to be plastic, and the reason for that is they found when they had two metal surfaces, it created a little bit of friction, actually wore the joint down faster than having one side being plastic. The cement that they use to kind of put everything in tends to loosen over time, and so that's also why it's a little bit harder when people that are younger, they tend to have that's why it's going to fail eventually. The cement tends to loosen. There's some contraindications to having this. That's in the box 12.10. There may be something as like active infection, having poor bone, paralysis of nearby muscle, inadequate motion. So not every person is a candidate for having a joint replacement. That's what it would look like here. This would be a total joint replacement. So we have basically this is trying to replace what the meniscus would be. This is that articular surface of the femur. This is the articular surface of the tibia. And you'll notice they replaced the whole joint. So you no longer have an ACL, a PCL, a meniscus. They took that whole thing out. So they replaced it with something else. And then you can have some arthrodesis. So arthrodesis is a joint fusion. Arthro, joint, desis being fusion. So this may happen if somebody's in later stage OA or if they have true joint instability where the mobility is less concerned, like a spine. You may see that we do some arthrodesis things. The joint position is going to depend on the needs of the patient and the goals of the patient. Whenever you fuse a joint, we kind of talked about this when we were talking about the muscle. If you fuse a joint, that has now become what we would consider hypermobile. It will no longer move. So in order for you to still do the things that you wanted to do, basically what happens is the joint above and below are going to become hypermobile to try to make up for that. However, now it becomes hypermobile. That's usually what led you to having problems in the first place. Now maybe it's sliding too much, that leads to having some more symptoms, and then you may end up getting another fusion. So in general, we usually see that one fusion has the potential to lead to more fusions above and below as the time goes on in the future. You can fuse things with nails, they can do it with screws, they could do it with plates, they could do it with rods, they could do it with bones. There's a whole lot of things that can be done in order to create a joint fusion. Basically, these patients are going to be immobilized for 6 to 12 weeks until the ankylose occurs. So basically that bone is nice and solid around whatever structure you put in to create the fusion. We want to make sure that we maintain above and below strength and range of motion to the best of our ability, and then we may see that weight bearing is restricted until evidence of that bone healing or that radiographic union. And when we see that hard callus, that's when we can usually start to do more weight bearing. If we don't see any bone happening on an x-ray, we don't want to weight bear just yet. So that's what that would look like. This is where in the spine they have some rods that they've used, and they can also use bones to help create more stabilization as well. And this is what it would kind of look like on x-ray. Somebody had scoliosis, as you're seeing in the first picture, and then they used what we call Harrington rods here to basically try to stabilize the spine and keep it. So you can imagine that this person is no longer going to get any motion from any of those spots that have the Harrington rods, so their thoracic mobility may be a little bit decreased, but they're doing it because the scoliosis was getting so bad and it started to compromise the internal organs and things of that nature. So there's other procedures that can be done as well. We kind of talked about all those things in there already. I think this is a repeat slide. Also a repeat slide. So this would be an example of where they go in and actually took an osteotomy. Osteoboneotomy means they're taking it out. So this patient had what they look like would be a collapse there, right? The lateral leg is a little bit shifted over. So what they did is they went through and they actually took out that part that has the dashed lines in it in order to create better alignment. And then they recreate the better joint alignment. So this is most of the time used to try to improve the joint alignment of different positions. We can have open reduction internal fixations of fractures. This is when they'll kind of open up the joint, then they'll reduce it, or they'll open up the area to kind of see the bone. They'll reduce it, meaning they're putting it in good alignment because usually the pieces are separated. They put it in proper alignment, and then they'll do an internal fixation, meaning they put a plate or rod or something to recreate what the bone is supposed to be doing. Osteotomy, that was in that previous picture that we just saw. I apologize, I had to jump it up ahead. So that's the end of this chapter. I know it's a long one. There's a lot of surgeries here. The main goal of this lecture was you don't have to know every single thing just yet. When you want to know more specific surgery, that's when you can go to your book in those later chapters 17 to 22 and it'll talk a little bit more about it. You also get a little bit more when you get to MSK as well. The big takeaways from this picture and that we're going to work on with the lab are what tissues, what type of surgery was it? What was the surgery for is the first thing. Why am I getting this surgery? Why would I get a surgery? What are some of those indications that we have? With the surgical procedure, what kind of things were involved? What did I have to cut through? What did I have to push through? What is this type of tissue surgery on? Knowing that bone will heal faster than muscle, muscle will heal faster than tendon, tendon will heal faster than ligament, ligament heals faster than cartilage. Depending on what's involved, or there may be multiple things involved, that will kind of help dictate how long my rehab is going to be. And reality, what is the purpose of this? What is the purpose of the surgery? If it was to stabilize the joint, my rehab is really going to focus on stabilization. If it was to improve function in cases like cerebral palsy, then that's my goal, is I'm really going to work on improving function. If it was to improve mobility and function, then I'm going to work on improving mobility. So based on what the surgery is for, that'll help guide you on what the things you really need to focus on. What tissues were involved, that will tell me, do I need to put this in the shortened position? Do I need to put this in the lengthened position? Do I need to work on what are my protective things, and also what motions may be contraindicated at this time, because I really want to still protect the surgical site. So getting those things and wrapping those things around your head is hard, but it will really help you as we kind of get through. And we'll work through it in lab as we're working through, particularly with that patient that has the post-op total hip replacement as an example. And then we're going to go back and we're going to talk a little bit about how, if they have fibromyalgia, how would that change things? If they have rheumatoid arthritis, how would that change things? And adding in those kind of confounding factors that can change how your progression of your rehab. So overall, this is not easy stuff. I get this. This is very dense and complex 3 chapters. It's the basis of a lot of things that we do. So the better grasp you have on this, the easier things are going to be for you when you're looking at a protocol and you're trying to figure out why we are doing this and not this. When can we do this? Or as you hear everybody else say, that, oh, this protocol is so old. This protocol, I don't follow the protocols. They're just there to help guide you. Protocols are help to guide you. You just have to know the reason for why certain things get stuck in. And is this the minimal phase, protection phase versus moderate protection phase versus maximal protection phase? So, if you guys have any questions, let's chat about them in class tomorrow. Take it easy, you guys.